Welcome. This is chapter 24, the second chapter in the module dealing with trauma. First one, of course, was bleeding. And keep in mind as we're going through this, I know y'all have started off early doing trauma assessments and, trauma assessment on day one. You haven't even had the trauma lectures yet, but that is simply because trauma is so involved that the earlier we can get you comfortable with that assessment. We'll do the same thing with medical, but the earlier you start getting comfortable with those, the easier it is going to be when you have to take that National Registry Practical Skills exam. So what's different between traumatic injuries and medical emergencies, right? There's some result of a physical force that's been applied to the body when we're dealing with trauma. With medical, heart attack, stroke, right? These are all conditions that are not caused by some outside force. The index of suspicion is that your awareness for potential serious unseen injuries, right? If someone's ejected from a motor vehicle, I have a pretty good, or my index of suspicion is that they could have suffered some serious injuries. So we want to make sure we do the proper assessment. We'll kind of go through that as we move through this chapter. But there's index of suspicion, and then there's also the mechanism of injury. Right? Mechanism of injury kind of describes the forces that were acting on the body that actually caused that injury. When we look for the definition of traumatic injuries, simply when the body's tissues are exposed to energy levels beyond what they can tolerate. So example of that, right? Kind of, you can twist your finger and it's got this joint and so it bends. But what if that were caught in a piece of machinery and then just continued to twist? So again, that's just part of the introduction to energy and trauma. Three types of energy: the potential, kinetic, and of course energy of work. Work is force acting over distance, right? It's going to just be your definition of that. Work is force acting over a distance. Now, as we move through and look at kinetic energy, I'm pretty sure you're going to have to just remember that formula. And, kinetic energy is equal to half the mass times velocity squared. So again, just be familiar with that. It doesn't come up when you're dealing with this trauma patient who was, again, ejected from that vehicle, but you should have this great index of suspicion that, yeah, that has the potential for very serious injuries. Potential energy, product of mass, force, gravity, and height, right? So if someone falls from, 2 feet just off a little step ladder, okay, that potentially could be bad, but let's compare that to the critical falls, generally that 20 feet or higher, and then that person landed on that same surface. Which one of those do you think is going to be worse? And again, that's an example of mechanism of injury. Those were both fall injuries, but which one do you think has more serious complications or potential complications from that? And of course, it's going to be the one that was from the greater height. Now, different mechanism of injuries, different types of injuries, right? Motor vehicle accidents versus a gunshot wound, potential stabbing, those are all different mechanisms of injury. Non-significant, and you got to be careful with non-significant, because if I look at this, it's just an injury to an isolated body part. But let's give you an example of a fractured femur. Well, certainly someone has potential to lose up to 1 liter of blood. Even though that's an isolated femur fracture, it doesn't really meet the qualifications of a non-significant injury. So again, you just kind of take this all with a grain of salt. A fall without the loss of consciousness can also fall into a significant range. If that person's on blood thinners or they take aspirin every day, then there's potential that that brain could bleed, more so for someone who is not on those medications. But looking at the significant injuries, more than one body part or system, falls from heights, vehicle crashes, multi-systems trauma where there's more than one body part that's actually a system that's actually affected. Blunt versus penetrating trauma. Again, blunt trauma, something that smacks against the body. It's not going to penetrate the soft tissue or actually break the skin. We start looking at penetrating trauma. There's stab wounds. There could be a piece of metal that was ejected from the vehicle and got into the person. It's going to be something that actually penetrates the surface of the skin or the body itself. It could be the head, You never know where that happens, but that's penetrating versus the blunt trauma. And they both produce different injury patterns, and it'll be important to understand, right, what lies within the right upper quadrant, the left lower quadrant, and if someone were shot or stabbed in that area, kind of have to imagine that path that that knife blade or that bullet is actually taking and what underlying organs could actually be affected. For the blunt trauma, let me move this guy up here. Some object making contact with the body. Now, fortunately, this guy is really good. And if I give you an example of blunt force trauma, bam, okay, that's making that direct contact with the body. But notice I didn't pierce it or poke a hole in his face. Motor vehicle crashes and falls. And with motor vehicle crashes, you can have blunt trauma. There can also be penetrating trauma. What we think about most often from that motor vehicle crash is the steering wheel into the chest. Even the seat belt can act as a blunt force trauma. And I know there's some pictures later on where you can actually see the seat belt mark on someone. And then we have to think about what that did to the underlying tissues and organs below that area. So look for the skin discoloration and pain, bruising, ecchymosis, the swelling or really abrasions that can be caused by that. High index of suspicion for things that you can't see, which again is why we always want to get the patient to the hospital as quickly as we can with trauma. Just because there's things that may be a slower bleed, it may start developing a little later on, even though your vital signs are stable, those things could crash. And this is why we're moving quickly. We're getting to the hospital with, or spending no more than 10 minutes on scene. As far as the vehicular crashes, when we start, there's three different types of crashes, right? First, the car can hit something, and it doesn't have to just be a car, a tree, an object, right? Whatever it is, that car's going to hit something. When you come around and you start doing your 360-degree tour, you look at the vehicle itself, right? What's indented here is that something that's actually called intrusion. So how far that metal was actually bent, and it could be on the passenger side, it could be on the driver's side. In this case, it's a front end crash where they looks like they hit that pole, but that's the first one. Car against object. Something has to be hit. Now, the passenger against the vehicle's interior. Again, as things start to compress, you look at wherever this potential driver was seated, well, potentially they hit their chest on that steering wheel. It could also be part of that intrusion on either the passenger or the driver's side door. But with those common passenger injuries, lower extremity, so right, the legs could be crushed, they could be caught underneath the gas pedal. There's flailed chest segments because you're not very well protected on your side, right? You get hit at the chest, you've got that sternum and there's more protection. But if someone's hit from the lateral aspect or on the side of their body, that can lead to that flailed chest segment. Two or more ribs broken or two or more places. And I actually think the book gives you two definitions of this, where it could also be three or more ribs in two different places. Remember, with flailed chest, the most identifying factor of that is that paradoxical motion. So as you're watching their lungs go up and down as they inhale and exhale, it's actually doing the opposite of that. And that is something that we can manage with a bag valve mask and really what's referred to as an internal splinting technique. Now, the last part that happens when the vehicle crashes is the internal organs against the solid structures of the body. So again, if this is the person you see in the picture there and he hits his head, well, what's going to happen to that brain? Is it going to shear? Is it going to hit the front part of that? Something referred to as a coup contra coup injury, but it's always something you have to be aware of and why it's so important to, when you scan that vehicle, look at the windshield. Is there any starring, or also referred to as a spider web in there? That is a clear indication that that person's head came in contact with the glass. Now, internal injuries, obviously not as obvious as the internal injuries, but again, we always want to address that most life-threatening need first, right? This is airway, breathing, circulation, those priorities that we're dealing with. Look for the seatbelt. Again, ask the person, were they wearing a seatbelt? Seatbelts are great when they're not wearing their seatbelt, or they're possibly or potentially worn incorrectly. That can actually cause more damage than obviously if they were wearing it the correct way. Look for the airbags. And when airbags deploy, there is this, it's a dried out sodium azide that is released into there. Doesn't mean the car is not on fire, because I don't know what's going on underneath or in the engine compartment, but typically people can inhale part of that, just irritant, but if they have asthma or other conditions related to their breathing, then maybe it's going to be a little more severe for them, and we have to treat that injury as well. But all the time we're dealing with the motor vehicle accidents, you do have to be aware that these non-deployed airbags can actually cause damage to the rescuers or the responders. So if their ability to turn those things off, you also want to disconnect battery cables. And again, this really isn't your job. That's part of the fire department's job. But again, just making sure that's done. You always want to avoid putting your head, face, neck right next to that, where that airbag's located, because it may actually still go off on you. So when you look at the seatbelt, again, this guy was probably wearing his seatbelt correctly. Maybe he wasn't wearing a shirt. It's going to end up on cops, but he's just driving around and bam, you can tell by the seatbelt mark, where was this guy seated, right? If we look at that shoulder and it's running over this side from my right down to my left side, and he was either the driver or he was a rear seat passenger on that driver's side. So again, that's why the seatbelts, and looking at him, maybe he wasn't in that same position when you got there, but he was ejected or he was thrown out. He might have taken that seatbelt off and kind of crawled out later. And now he doesn't remember, was he driving? Was there a passenger? But sometimes that can give you additional clues to what was actually going on at the scene. Remember, at this point, we're trying to gather as much information as we can, just so we can do what's best for that patient, right? Because we got to find the injuries. We got to try and potentially fix those injuries. In the rear end crash, this is more of a whiplash type injury, right? So here's my guy, and he's sitting there, and then he gets hit from behind, and that head is likely to whiplash back. So again, there are certain injury patterns we may see based on the types of crashes that you come across, but it's a pretty common one for the sore neck to be present after something like a rear end type of collision. And how much force was applied to the body, this acceleration type of injury that can actually cause some shearing of the brain. Again, this is why we're going to stabilize this person, treat them as best as we can, and get them to the hospital quickly. The lateral crashes, formerly known as the T-bone, but when someone's hit from the side, again, depending on the size of the vehicles that are involved, you might have a large truck that hits a smaller type of sedan or a passenger car. Where did it hit? Did it hit the person on the driver's side? Did it hit him on the passenger side? Was there a passenger and a driver? But again, those can result in this lateral whiplash, again, where the neck is just pushed out forcefully and quickly. And when you see intrusion again, how much metal is actually bent into that person, right? Because this is where they're seated, and as that metal just goes, we have to worry about those lateral chest injuries, the drumming from this side. Again, does it cause some fracture of the ribs, and now the person's suffering because they have a collapsed lung, the pneumothorax? So again, high index of suspicion anytime we're dealing with these crashes. But there's also organ damage from that third collision, right? So you have your kidneys, and as they sit back in that retroperitoneal space, someone struck from the side, those things can actually just move within that area of the body and potentially have some damage. So why we need to get them to the hospital, so important. In the rollover crashes, again, ejection, partial ejection, the most common life-threatening injury. Again, we're talking about a vehicle that's just rolling over. Some of the vehicles that are more prone to this are the trucks or the SUVs, which is with their, because they're up a little bit higher. But was the passenger restrained? Were they not restrained? All these questions and assessments that we're going to do as we approach that area. Rotational, similar to a rollover, but here it's simply spinning round and round versus up and over. But it can still create that force where if someone isn't properly seat belted in, they can be ejected or partially ejected. And do they come and hit the side of a light pole or something? And, there's so many dangerous possibilities with all of these types of crashes that we're looking at. So different part of trauma, the car versus pedestrian. Again, so true. These can be pretty graphic and apparent of what actually happened. I didn't see it in here, but we also have a consideration. Is this that person thrown up and over? So again, depending on the person's height and how tall or low that car is, if it hits them more, say by the knees, then it may actually propel that person up and over the vehicle. And there's just so many entry patterns that can be created by that. I won't say this is worse, but they're all really bad. If you have a larger vehicle, such as a truck, and it comes and hits someone, that person may actually be propelled down and under. So, right, as that vehicle hits them, and then does the person continue to run over them as they're going down through the vehicle? But that's what it means by graphic and apparent about what's going on that scene. Vehicle speed, finding out if they were thrown through the air. Again, all of these are just things that are going to be important to try and figure out. But your primary concern at this point, in addition to your scene safety, is making sure you're checking the person's airway, breathing, circulation. We're obviously going to want to maintain that C-spine in a neutral inline position. That's something your partner can address. But looking at the vehicle for any structural damage, again, this is a little more prevalent when we start getting to the bicycles, because at least with the bicycle, that may offer what minimal form of protection that is. But look at the bike, then you can actually see where that person was actually struck. We want to make sure we look at the helmet as well, because the helmets are supposed to absorb some of that pressure versus just going straight into the brain. And all of these, the car versus bicycle, the car versus pedestrian, even the majority of those motor vehicle accidents, it's going to be something you want to make sure you're taking and maintaining the spinal immobilization for. And spinal immobilization, so as I mentioned this, that'll be something that you go through when we learn about putting someone on a spine board. But there's also something referred to as spinal motion restriction. So if a patient does not meet criteria, all of these patients will meet criteria, but if they don't meet criteria, it's a 5 mile an hour, somebody backed into somebody and they don't have pain in the neck and they can wiggle and move their fingers fine and they have good neurovascular status, then maybe that person doesn't get spine boarded. But I bring that up because the spine board is something that's no longer through the NREMT practical skills. But as far as testing goes, we'll still test in our manner, but it won't have to be something you're doing on the last day of class like it has been for I can't even tell you how many years that's gone on. So that's out because of spinal motion restriction, but we still obviously want you comfortable with that spinal treatment and log rolling and getting someone on the board if it does need to be done. The car versus motorcycle, and there's different positions where the motorcycle may actually be struck, can have a big difference on how far, or if that person does actually fly from that motorcycle, similar to an ejection. But hopefully they've got some protection on, right? I think the first motorcycle I had, I went into the shop and said, you got a $5 head, get a $5 helmet. So again, hopefully they're wearing the good helmet, leather to protect them from sliding on that pavement. Nobody plans to go out and get into a motorcycle crash, but it's just unfortunate. A lot of people wear shorts and little flip-flops and just kind of crazy. So hopefully there's the right gear on. That's going to go a long way in protecting all that person's integumentary system. So when you do get to the scene, look at the motorcycle. Where was it struck? How was it hit? The side that has the most damage, right? I'm driving the motorcycle and a guy hits me from the right side, there's a good chance that my right leg, maybe it's a lower or even that femur itself, has suffered enough force that it could break that. So we have to be aware that looking at that motorcycle can also indicate what type of trauma that patient has suffered. And if you get to the patient first and there's obvious injuries, that's fine. Again, I'm not saying you spend 10 minutes looking at the bike, but just having that, hey, how fast was this guy going? That's very similar to intrusion that we can see on those lateral impact collisions as well. Distance of skid on the road. And again, the deformity of the helmet, right? How does that helmet look? Does it have cracks? And with the helmet, we really want to leave those things on unless there's a problem that's impeding the airway and breathing for your patient. Motorcycle helmets nowadays, you really have to get up and pull those things, because you can actually, as you're taking a helmet off, actually pull or misalign that person's spinal column. So we're careful about leaving the helmets on. We certainly take them off if there's an issue with the airway or breathing, but it would be ideal if we had a patient who was breathing and they were actually able to leave that on until they got to the hospital. With the head-on crash, again, with this, typically that bike stops and that momentum is going to carry the driver of the motorcycle forward until he stops. On the angular crash, again, it's just someone that's actually hit from the side, but direct crush injuries to the legs, like I was talking about earlier, either side could be affected, because not only is that trauma going to affect them when they're hit directly by the vehicle, but then potentially when they land or are forced down into the ground or even propelled up and over. The ejection, again, riders traveling at this high speed are going to keep moving until something stops them. And there's a lot of things that can stop someone who's being propelled through the street. Could be another car, it could be a light pole on the freeways, it could be those sharp little edges that are running around. There's so many things that can happen to the person once they're ejected from the vehicle, or in this case, the motorcycle. On the controlled crash, again, there are ways that certain drivers have a technique to try and minimize their involvement in injuries in a crash, where they just kind of have to let that bike go. But you got to do what you got to do, right? You can get another motorcycle, but you can't get another head. Falls, and here's what I was referring to, more than 20 feet is considered a significant fall. How far did they fall? What did they land on? What surface did they land on? Those are all things that we need to be concerned about when we're assessing these types of calls. Internal injuries, and something that may not be prevalent at this moment as you're palpating the abdomen, maybe it's soft, non-tender, but remember, we recheck vital signs for critical patients every 5 minutes. So you may find during your reassessment that, oh, this is rigid, it's distended, or even if you put that backside of a gloved hand on there, you may find that that area is warm, indication of something that's called a hot belly. But again, it's always that index of suspicion. I'm always worried that this looks okay now, but how's that patient going to be in, as little as 5 minutes? Patients that do land on their feet, less severe internal injuries, but they can have fractures of the ankles. Then energy can be transferred up, not only to the tibia and the fibula, but to the femur as well, right? We have to consider how far they fell, how big or how much weight is associated with that fall, all different things to consider. And here's just an example of someone that's fallen. Again, did they fall from this branch up here? They jumping up and down on the tree? I don't know. But the height of the fall, the type of the surface struck, those two things are always super important. And then how did they land, right? Was it straight on the ankles? Was it flat-footed? And then more of that energy was transferred up and it can't even go and compress part of the spine. So lots of concerns with our falls, but we can assess each patient individually and make the appropriate treatments as necessary. Penetrating trauma. This is cool. This young man has a knife stuck in him. That is a penetrating trauma. It could be accidental, meaning you didn't really notice and you just kind of turn into something, or you're running out in the woods. I don't know why you do that, but you trip and you fall and a branch goes straight into the arm. Okay, that's more of an accidental. May also be intentional. This case, it looks like it was a weapon that was actually used on the person. So with low energy penetrations, again, talking about stab wounds, things that are low energy, right? Turning into something and actually having that break your skin or potentially stick in there. As far as knives go, and with, again, stabbing someone, again, it could be that the knife is put in and maybe someone twisted that as well. That leads to more bleeding. There's more potential for those internal organs as well. So again, if the scene is safe and you can make that assessment, you may actually be able to look around the knife and see if there's, more, rounded cuts than just one puncture wound in there, but all just parts of a good assessment for penetrating trauma. And as far as the path goes with bullets, Okay, you got to know this, that bullets can ricochet, right? Something goes in and it bounces around, and who knows how much damage that can do, or where it actually ends up. The path the projectile takes, again, is someone shot, from 20 feet away. Here, is it up close and it was placed at this portion of their body? Again, so many potential issues with all of this, right? But that bullet doesn't always travel that just nice path. Again, it can go in, depending on the shell, maybe that stuff is actually going to disperse or break up in the person. Fragmentation is what I'm referring to with that, but that is designed to increase the damage. And again, that's something we're going to have to concern ourselves with. Cavitation, there's two different types of cavitation. There's a temporary and a permanent cavitation. But the temporary cavitation is a larger or wider area versus the permanent, right? The permanent is simply that structure itself, but as that force is applied, it'll have that separation of the tissue. It's a temporary cavitation, but it still can do more damage to that underlying tissue, increase the bleeding if that were going through an organ. And if it's a solid organ, it leads to a lot more bleeding. If it was hollow, maybe it causes that to rupture. So, but that's just cavitation. And remind us in class, we have some really cool videos on cavitation. You can probably find the same things on YouTube, but things going in slow motion, and you can see how that tissue actually starts to separate. And that's a result of those cavitation. Penetrating trauma, more on this. When we think about the relationship between the distance and the severity of the injury, well, that's going to vary greatly depending on the type of weapon, right? Was it this caliber? Was it that caliber? So again, always try and find out. You don't have to be a ballistics expert on this. You just really want to know, well, what was this person potentially shot with, right? They were shot with a 22 versus a 45, whatever it is. Just try and ascertain that information as you report that to the hospital. Remember, this is a whole team thing. So anything I can share with them, it's going to be beneficial on how they're actually going to, make that person survive. Or maybe it'll be definitely some welcome information, if you will. On blast injuries, primary, secondary, there's a tertiary, there's also a quaternary injury. So on the first part, due entirely to the blast itself. Now, damage from flying debris, I'm not going to tell you how to make a pipe bomb or a dry ice bomb, but, sometimes you put certain things in that, and that would be an example of a secondary injury where there's actually things that are flying free, or even something that was, in one area, and then it caused it to be projected into the patient. The tertiary, when the victim's actually hurled by the forces of the explosion. And then when we get to the last one, maybe it's burns. Gas is actually started by the fire, if there was the fire or the blast that was there. Respiratory, it could be toxic gases that have been created from this. The crush injury, so something explodes and then the building collapses on them. That's what we're looking at with that type of injury. But there's usually combinations, right? You won't typically just have one or two of these. Usually having the 4 types is not uncommon with a blast injury. And the areas that are affected, and a lot of times that middle ear, the lungs, the GI tract, and those are the ones that are just more susceptible to pressure changes. The ear, of course, and that ringing in the ears or actually destroying the eardrum is certainly possible. It's something that's going to require, this is a trauma transport, and definitely to a level 1 facility would be encouraged. The pulmonary blast injuries, short range exposure, some detonation of an explosion, right? That really loud sound that can actually cause that damage to, well, in this case, the lungs. The disturbance in the vision with air embolisms that can be created, changes in behavior, level of consciousness because of that, potential head injury, and other neurological signs. Again, neurological signs, I don't want to say they're going to be the same things you would see in a stroke, but always checking the memory, right? Do they know who they are, where they are, or have they actually, lost that? Maybe some type of amnesia that's going on, or is it related to an increased pressure that's developing in the brain? The solid organs, again, they seem to be relatively protected from that shock wave, and that's why the ones you saw before were more hollow organ issues. But with a solid organ, the concern with those is if they are cut or nicked or damaged, then those things can bleed, right? They're very vascular. Neurologic injuries and the head trauma, most common causes of death. So again, and this could be relatively immediate after the accident or the incident. So again, the rapid transport, important. What are we gonna do if someone has these neurological injuries and they happen to need a neurosurgeon? Well, that's why we want the level 1 facility, right? Definitive care that can take and manage that person throughout the event. The traumatic amputations, and again, a traumatic amputation and explosion, again, ask to see the Boston Marathon bombing. There a lot of people were actually saved in that because of the improvised tourniquets and just the means with the bystanders used in order to stop the bleeding from these accidents. Multi-system trauma, again, more than just one body system, right? We think back to the significant versus non-significant. This definitely falls into the significant mechanism of injury. The head and spinal cord, well, those two things go together. The chest and abdominal trauma, chest and multi-extremity fractures. And I know when we talk about multiple extremity fractures, but depending on which area of the bone is actually fractured, right? The femur, you got 2 femur fractures, that is a critical patient. I'm going to go so far as to say you have that 1 femur fracture where up to 1 liter of blood can be lost, then that has some potential serious side effects as well. But letting medical control know that you're on the way. Again, this is going to a trauma facility. The golden principle is pre-hospital trauma care. Okay, you've got, right, that golden hour. That golden hour is where that clock starts ticking, but it's actually from the onset of the accident or injury. It may have taken you 10 or 15 minutes to respond and actually get to that scene. You know, you have your platinum 10, that's the 10 minutes that you're going to spend on scene with the patient and hopefully no less. And this is more of a review of the trauma sheet, because when you start off, right, what's my first 2 steps on there? Oh, I've got my PPE on and I've ensured that the scene is safe. So your safety, I need to be safe, my partner needs to be safe, and then we obviously want to protect the patient. But again, you and your partner always come first. The need for additional personnel or equipment. This is something that someone needs to be extricated, and it's a complex extrication. It's going to require tools. Again, those are all just things that will be determined once you're on scene. And evaluating the mechanism of injury. So looking at the vehicle, looking at the restraint system, looking inside, doing that 360-degree walk around. Because if you've got someone who is unconscious, unresponsive in that vehicle, you know, they're not going to be able to tell you if there was another passenger or potentially the driver that is actually missing right now. So again, people can be thrown, you know, a long ways after an ejection, or even, you know, the partial ejection where they may be crushed underneath the car. But always do that survey or walk around, because again, we don't want to miss anything. Manage the life threats, and these include the address where you need to address the airway, make sure they're breathing. If there is any, you know, arterial spurting of blood, we want to put a tourniquet on that. That's another example of a life threat. Then we can start worrying about your airway, your breathing, your circulation. You'll potentially drop in the OPA, could be an NPA, but not if there's any head trauma that patient has suffered. The shock therapy, again, shock therapy involves the positioning of the patient, the high flow, high concentration oxygen, of course, stemming the flow of any blood loss that person is having. The spinal immobilization, it's kind of funny because when I see spinal immobilization, isn't that actually much higher on the top of this sheet, right? I don't worry about well, of course we do airway, breathing, circulation, but spinal precautions are one of the first things you're actually doing, and you just verbalize your partner to do that. I would have my partner maintain inline immobilization of that person's head as I'm approaching them. And of course, transporting to the appropriate facility, which in here is always going to be a trauma center. So when we look at definitive care, and there's some questions about, you know, what is definitive care? What does that mean? That's ultimately what that patient needs to, again, try and address and make them better. In this case, we're looking at surgery. Again, what type of surgery, whether it's a neurosurgeon, trauma surgeon, because they're repairing bones and putting rods and screws in there. Whatever it is, we want to make sure they get to the hospital to receive that care. Sample history may or may not be obtainable on an unconscious and responsive trauma patient. But remember, we can look for medical alert tags. There's different ways that we can gain that information. Maybe there's bystanders that can help us with it. But just do what you can, but don't, you know, spend the entirety of your 10 minutes just working on a sample history. There's more concerns that we have at this point. As far as the ALS intercept or air medical transport, again, if you've got multi-system trauma, again, the hope is that that would be dispatched as an ALS call. But again, you may be closer in that area, and so you have to go and manage or stabilize that patient, and then understand once the ALS unit gets there, you guys will work as a team and then be able to transport that patient to the appropriate facility. Now, when the patient has experienced a significant mechanism of injury, critical condition, well, that's where we do this rapid physical exam. And we'll take you through the rapid physical exam. We, again, do more of these in class. But if they have a non-significant MOI, what they're saying is just focus in on that chief complaint, right? If I can tell you, yeah, I was doing this and I broke my ankle, great. We don't need to check absolutely everything in detail like we would if they're unable to tell you what's wrong with them, right? This all relates back to the find and fix. And if I can tell you, hey, look, yeah, this is my leg. This is where I hurt it. No, I didn't strike my head. Nothing else happened. Okay, that's great. But that's the example of the latter versus the former. Injuries to the head. And we always need to be concerned that anytime someone struck their head, that they could be bleeding internally. You know, the swelling of that tissue and something that's known as ICP or intracranial pressure can certainly be increased. The brain is, you know, it's enclosed container. And if they suffer some type of injury to that, what happens when you bang your arm? Well, if you bang it hard enough, it can actually swell and it gets bleed on the inside. Same thing can happen inside the brain itself. So there's frequent neurological assessments or examinations as it's requesting. Again, we keep looking at the eyes. The eyes can show up. You can see some differences in the pupils. Remember, we would certainly hope that the pupils are pearl. Pupils equal round and react to light. And although they may start off that way, you know, how are they? Or is the patient starting to lose that consciousness? Is he getting combative? All signs of some neurological insult or injury. You might not have those obvious signs, but this is why we keep trending them. That's why I'm checking their vitals every 5 minutes to see how this patient is actually doing. And that's why we check it. Again, it's called trends. So we monitor that patient, and then you have something you can actually compare to now and then 15 minutes later. And in between that, the vital signs all seem relatively stable, or you see them slowly adjusting, and now you're getting to something that's more concerning. The neck and the throat, different injuries to those areas. Now, we'll explain this one to you as well, but when you have injuries to the neck and the throat, tissues, again, can swell. It can end up blocking that airway. It can even impede the flow of blood up to the brain. When you look at decap BTLS, here's my guy. And my guy actually has some open injury right down on the left side of his neck. So deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling, right? Those are all things we're looking for as we complete that trauma assessment. Again, if you say that one time, it's pretty evident that you understand what decap BTLS means and what it is. So again, you may feel better just saying decap BTLS, or you can say I'm searching the entire body. When I get to the chest, what are you looking for in the chest? Decap BTLS, or deformities, contusions, abrasions, punctures, burns, tenders, lacerations, and swelling. Either one is fine, as long as you've demonstrated you know what that information actually means. The penetrating injury, again, that's my concern with this guy. He may actually have some air embolism where air gets into that vascular space now and it ends up going to the pulmonary system, and now he's got this, huge embolism, and we can't figure out what's wrong with him. So again, this is why we're assessing all of those areas, in particular right now, just at the neck and the throat. But the crush injuries, again, you've got the cricoid cartilage that sits here, this little hyoid bone. And again, if someone was just snapped up against the neck, done something to the equivalent, then we have concerns that that's going to impede their ability to breathe. Breathing, right? We've got to have airway. In the chest, the heart, the lungs, the superior, the inferior vena cava, the aorta, right? All the areas that lie within that space. Broken ribs. What's wrong with a broken rib? Well, it becomes harder to breathe. It's more painful. The heart itself may suffer some contusion. Later we get into cardiac tamponade and what that'll look like. But laceration of a large vessel, such as either one of your vena cava or the aorta, lead to massive internal bleeding. Pneumothorax, so the collapsing of a lung, and then an open chest wound, or what we call that sucking chest wound. Again, that's where you're putting that dressing on. It's an occlusive dressing, right? It's going to stop the air from rushing into that space and continue to pressure the lung down. Injuries to the abdominal area. Again, you've got organs in your abdominal area that are carrying a lot of that rich oxygenated blood. And if those are damaged or cut or lacerated, it's going to lead to a mass insanguination. Solid organs, these things can tear, lacerate, or even fracture. The hollow organs rupture, and they tend to leak the digestive chemicals. So as we're assessing the abdominal region, we may find more of what's called a rebound tenderness. As I press, it doesn't hurt. Come down, it does. But again, that's why we're assessing all different areas of the body and their system. Remember, when we're doing this, that patient's not able to verbalize where their actual pain is because they're unconscious or they're unresponsive. But again, it doesn't always have to be that way in trauma. On your scene time, highlight this, know it, limit your scene time to that 10 minutes or less. We want to make sure we're getting them to the appropriate facility as quickly as possible. Sometimes extrication will drag that out, but that's understandable. But it shouldn't be a process of you wanting to get your blood pressure before you put that person in the back of the ambulance. Different types of transports, and it could be a helicopter that's most appropriate, or it could be a ground unit that, EMS units, they have EMTs, there's EMTs and paramedics. If you're calling for a helicopter, you're more likely to get a critical care paramedic or even a nurse as well that is able to do just more invasive procedures for the patient. That's why we consider, hey, let's fly them out. They just get better treatment potentially. Your selection, this gives you an example of the level 1 through 4. A level 4 facility, ATLS, it's just advanced trauma life support. But look at the difference in a 4 and a 1, right? This one has every aspect of trauma care. They've got a surgeon that's on call or on duty there. Again, and that's why we want to get them there. That's definitive care at its finest. Special considerations. Well, yeah, we should always be calm. We should do an organized assessment. Sometimes it is hard because there's, these gross or obvious injuries that you come across. But remember, don't get the tunnel vision, treat your life threats, do no harm to the patient. But if you ever feel you need it, calling that ALS backup, or again, meds control, or even putting a helicopter on, it's just, if that's what you feel like you need to do, then you should certainly do it. You could certainly justify that decision making. So I always tell you this is going to come up, right? Here's just the first review question we'll look at. Kinetic energy is a calculation of, weight and speed. Let's see, weight and speed. Kinetic energy is a calculation of mass and velocity, speed. So, right, you see what they did? Mass. Isn't mass equal to weight? Yes. Velocity, is that equal to speed? So they might have worded it differently, but it was still giving you the idea that, hey, that's what we're looking for. So that is the introduction to trauma. From here, you'll have an